Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today, we're talking about diabetes with pregnancy. We're not talking about diabetics who get pregnant. We're talking about pregnant women who develop diabetes because they're pregnant. You know, if you're anything like me, I have a tendency to think that just because there's a comorbidity or a secondary issue like pregnancy going on, we must treat diabetes very differently. Y'all, we don't treat it that much differently. There's a couple differences. You probably want to know about them before you take your NCLEX or your standardized test. But for the most part, they're not that much different. So watching this video will also, in general, help you understand about diabetes. Stay tuned. Hello, Clinic Review family. It's Dr. Sharon from Clinic Reviews, the very best NCLEX review in the entire universe, in my opinion. You can go to clinicreviews.com to find out more about our on-demand NCLEX review that is taught by the GOAT himself, Mark Klimek. You can find out more about our small group tutoring or our streaming service. Today, I'm going to continue with the Blue Book. You can get the Blue Book at Amazon, or you can get it as an app at clinicreviews.com. So just so you know, there is another video on diabetes that I have put out, but let me just do a quick introduction to diabetes. So what you have to understand is there's two types of diabetes. There's type 1. Type 1 is when there's no insulin, which means they have to take insulin. Type 1 is called insulin dependent diabetes. It's usually picked up in childhood or adolescence. And if they don't take insulin, they die. Then there's the second type of diabetes, which is type 2 diabetes. This is where there's insulin resistance. This is generally picked up later in life, usually midlife to later. It's very closely associated with genetics and with obesity. And the reason it's associated with obesity is because insulin resistance is a result of obesity. So what happens is you have insulin. Insulin is the key that unlocks the lock to the cell, right? And then it unlocks the lock. The cell door opens and glucose or other carbohydrates can get into the cell to be used for energy. So if you have no insulin, that gate or that door is never going to open ever, right? So you have to take insulin in order to be able to open up that door. But if you have insulin resistance, I want you to imagine old school locks. I don't know, most of the locks I have now are like press the button. But if you've ever used an old school lock that actually had a key, sometimes you had to jiggle it pretty hard to get it to actually open the door. That's what I would call resistance. That's the lock resisting the key. Usually that was because the key was new and the lock was old. Did you ever make a copy of a key that you lost and then you tried to use it and it didn't work nearly as well because you had a new key and an old lock? That's a lot like insulin resistance. You've got a key, but the lock is getting old and it's starting to resist the key. Even though the key is just fine, the lock is starting to resist it. And obesity is one of those things that can change the lock itself. So it's more resistant to the key, which is insulin. And so diabetes that develops during pregnancy is type 2 diabetes. It's insulin resistant. And they don't have to have any history of diabetes in order to develop it. We're going to talk about why it develops. But type 2 diabetics can control it. The number one answer to control type 2 diabetes, whether they're pregnant or not, is diet, number one, exercise, number two. Okay, diet and exercise, the top two answers. Because if you can reduce the number of carbohydrates or glucose that you take in, it's easier to use the insulin that you have. So, all right. So let's go ahead and get started. So remember, the Blue Book is a book of facts. So I'm going to be testing you on the facts of the Blue Book. Not a lot of clinical reasoning here. Clinic Reviews, as part of their NCLEX review, teaches more conceptually about how to manage type 1 and type 2 diabetes. Okay, so that's part of the reason I'm not going super in depth with it here today. Question 1. During a prenatal visit, a patient asks why she developed diabetes during pregnancy despite having no history of diabetes. The nurse's explanation should include which of the following: increased insulin sensitivity during pregnancy, placental hormones causing increased insulin resistance, decreased need for insulin during pregnancy, increased physical activity during pregnancy. Okay, so we know that gestational diabetes, or diabetes that starts because of pregnancy, we know it has nothing to do with lack of insulin, and it has everything to do with resistance to insulin. So increased insulin sensitivity doesn't make any sense because the problem is insulin resistance. So increased sensitivity is the opposite of that. So we're crossing off A. Placental hormones causing increased insulin resistance. Well, whether or not you know placental hormones cause the increased resistance, you know increased resistance is the issue. So let's keep B on the list. Decreased need for insulin during pregnancy. Well, that's the opposite of diabetes, right? The opposite. So no, C is absolutely wrong. Increased physical activity during pregnancy. Well, there's certainly no guarantee there's increased physical activity during pregnancy. And increased, just as a general rule, increased physical activity lowers blood sugar. It doesn't cause you to have resistance to insulin. So the only answer that makes any sense is B. And this tells you the pathophysiology of gestational diabetes. The reason women develop gestational diabetes, or diabetes, type 2 diabetes with pregnancy, is for some reason, and I don't think we know why, in some women, placental hormones cause increased insulin resistance. There are some risk factors for it that we're going to talk about. But why it happens, if we knew why it happened, y'all, you could make $1 billion curing women of gestational diabetes. Which of the following are risk factors for gestational diabetes? So this is just facts. Do you know it? Younger age, obesity, family history of type 2 diabetes, history of type 1, history of miscarriage, previous large birth weight, history of hypertension, or lack of prenatal care. Now, you've got to understand there's a difference between risk for. So if you have this is more likely to happen. And then you have concurrent problems. So concurrent problems don't cause each other. They just tend to occur together. Risk factors are things that you're at risk. If you have this problem, you're at risk for this to happen. So A can cause, to a certain degree, cause B. Okay. When you have concurrent problems, two things that happen together, they're not causing each other. They just have a tendency to occur together. Okay. So we're talking about what of A, what are the A's that can cause B? B being gestational diabetes. Younger age, no. Older age is a risk factor for gestational diabetes. Obesity, yes, I told you obesity is the number one reason that we have insulin resistance. So obesity is definitely a risk factor for gestational diabetes as well. Family history, yes, I told you obesity and genetics are the two main reasons that people in general develop type 2 diabetes. And that's also true for gestational diabetes. Family history or history of type 1. So y'all, if they are diabetic when they become pregnant, that is not the definition of gestational diabetes. Okay. Gestational diabetes is women who are not diabetic and then they get pregnant and they become diabetic. So if they're a type 1 diabetic when they get pregnant, they're not going to develop gestational diabetes. They're already pregnant. They're already diabetic. Okay, so D, no. History of miscarriage. I don't know why, but history of miscarriage is a risk factor for gestational diabetes. Previous large birth weight babies, yes, that's another risk factor. So women who've had a miscarriage in the past, or women who've given birth to large babies in the past, greater than 9 pounds, are at risk to develop gestational diabetes with their next pregnancy. History of hypertension, no. Hypertension occurs concurrently with gestational diabetes. So if someone who has gestational diabetes, they do have to manage, or monitor, I should say, monitor their blood pressure because it can go up. They tend to occur together, but they don't. Hypertension doesn't cause gestational diabetes. Lack of prenatal care. Again, lack of prenatal care does not cause gestational diabetes. Lack of prenatal care can allow gestational diabetes, to go uncorrected for a longer period of time, but it doesn't cause it. So these are the main causes. The only one that I did the opposite of is older age. So older age, obesity, family history, type 2 diabetes, history of miscarriage, previous large birth weight babies. These are the primary risk factors for gestational diabetes. Which of the following symptoms in a pregnant woman may indicate gestational diabetes? Hyperemesis gravidarum, bradycardia and hypotension, extreme fatigue and low blood pressure, low blood sugar, frequent urination, and excessive thirst. Well, extreme fatigue and low blood sugar is the opposite of what diabetes is. Okay, so we're crossing that off. I told you hypertension goes along with gestational diabetes. So B doesn't make any sense. So which is more likely to be a symptom of diabetes? Hyperemesis gravidarum, which is throwing up constantly, or polyuria and polydipsia? Y'all, you know polyuria and polydipsia are the symptoms, signs and symptoms of diabetes. Everybody knows that. It's no different when you're pregnant. No different. Polyuria, polydipsia, the signs and symptoms of diabetes. A pregnant woman with gestational diabetes is at increased risk for which of the following complications for her baby? Microcephaly, low birth weight, macrosomia, or Down syndrome. Y'all, I'm teaching you vocabulary here. I think if I had used the words that define macrosomia, you would have answered it correctly. Macrosomia is a large birth weight baby, a large birth weight baby. And I think most of you know, if not all of you know, that having a large birth weight baby is the concern for someone with gestational diabetes. One of the concerns, one of the many concerns. And so the word for large birth weight baby is macrosomia. Which of the following is the most appropriate initial treatment for a pregnant woman diagnosed with gestational diabetes? So initial: insulin therapy, oral hypoglycemics, dietary modifications and exercise, immediate induction of labor. Y'all, what is the number one treatment for diabetes type 2? Type 2 diabetes. Do not tell the National Council of State Boards of Nursing that anything other than diet and exercise are the best treatment for type 2 diabetes. Does that mean that every woman with gestational diabetes will be able to control it with diet and exercise? No, because in real life, there has to be compliance and outside factors that go into it. But on the NCLEX, it's a perfect world. And so what we're going to do when someone is diagnosed with gestational diabetes is we're going to try diet and exercise to begin with. We will expect the mom to probably be induced a little early because we don't want macrosomia. Oral hypoglycemics, y'all, cause birth defects. I'm giving you the answer to a future question right now. So pay attention to what I just said. We do use insulin if diet and exercise don't work. What is the primary concern for a neonate born to a mother with poorly controlled gestational diabetes? Neonatal hypoglycemia, hyperbilirubinemia, neonatal sepsis, or neonatal polycythemia? So the correct answer is neonatal hypoglycemia. So this is most often a problem when mom is ketotic during pregnancy. Now, when mom is ketotic during pregnancy, ketotic means there's not enough glucose. And so mom is or not enough glucose being used. They're hyperglycemic, but their cells are resisting it to the point that they're having to burn fat for energy. So when mom is burning fat for energy in the absence of glucose, in the absence of burning glucose, then mom releases ketones. Ketones can cause brain damage in the baby. Okay. So that can cause brain damage in the baby, but that's not what the question, none of those are answers here. Okay. So the other problem, that not only is brain damage a concern if mom becomes ketotic, which means she's not controlling her blood sugar well, she's chronically hyperglycemic. The other concern is that baby will become hypoglycemic because they're in a hyperinsulin state. When they're not able to use the insulin that they're producing, they start producing more and more and more. Their pancreas works, so it starts producing more and more insulin. So when they're then born, they're in a hyperinsulin state and they can become hypoglycemic. Okay, so if it said brain damage was a concern, if it said which of the following is the risk for a mom with gestational diabetes who's not controlling it well, I would say brain damage to the baby is the risk. But here it's saying for a neonate born to a mother with poorly controlled gestational. So the problem after birth is neonatal hypoglycemia. Which of the following statements by a pregnant woman indicates an understanding of how gestational diabetes might affect her future health? Okay, it's not about the baby, it's about mom. So remember, she didn't have diabetes before. She developed gestational diabetes, and she's saying, how is this going to affect my future health? Gestational diabetes has no impact on my health after pregnancy. even if you were guessing, I hope you would not pick that. That's very unlikely to be true. I am at an increased risk for developing type 2 diabetes later in life. That seems reasonable. If I'm just using my common sense, I know gestational diabetes is a type 2 diabetes. And I know that women who have a family history of type 2 diabetes are at increased risk for gestational diabetes. So it makes sense to me that if a woman has gestational diabetes, it makes sense to me she would be at increased risk for type 2 diabetes later in life. I won't need to monitor my blood sugar levels after delivery. That doesn't make sense. She's in a hyperinsulin state. The placental hormones are causing her to resist the insulin at the cellular level. I would think there's going to be a lot of blood sugar fluctuations after she delivers. So I would say, no, you got to keep checking it for a while, sis. Gestational diabetes always resolves immediately after birth. That doesn't make sense. The word immediately is not a good NCLEX answer because very few things happen immediately. It's sort of an extreme word. I'm not saying it's always a bad word, but it's an extreme word and I resist using it if I can help it. So gestational diabetes usually does resolve after birth. That's true. And the reason I know immediately is an extreme word is because if I take the word immediately out of the sentence, I like that answer a lot better. So gestational diabetes does usually resolve. Well, not always. It doesn't always resolve after birth. It usually resolves after birth. So D is just too extreme of a statement. So B is the only one that makes any sense here. It's the only one that gives me common sense tells me it's the right answer. A pregnant woman with gestational diabetes is advised to check her blood glucose levels regularly, which range indicates optimal fasting blood glucose for a pregnant woman with gestational diabetes. 70 to 95, 120 to 140, 50 to 70, or 100 to 120. Y'all, this is when I say pick the answer that's the same even if they're not pregnant. Okay, don't go off and going, well, because she's pregnant, it must be okay for her blood sugar to be a little higher. It's not okay for her blood sugar to be a little higher just because she's pregnant. 70 to 95 is the recommendation for fasting blood sugar, whether you're pregnant or not pregnant. A pregnant woman who is 24 weeks gestation is suspected to have gestational diabetes. Which of the following tests will be used to confirm this diagnosis? 1 hour glucose tolerance test, 3 hour glucose tolerance test, fasting blood glucose, glycosylated hemoglobin. Glycosylated hemoglobin is not used to diagnose anything. It's used to monitor long-term blood glucose levels. Fasting blood glucose is a screening test. It's not a definitive diagnosis. So we're going to have to pick between 1 and 3 hour glucose tolerance test. And the correct answer is 3 hour glucose tolerance test. A woman who has been diagnosed with gestational diabetes asked the nurse if she will be started on oral medication for her diabetes like her mom takes. The nurse's best response is yes, oral hypoglycemics are the best way to decrease blood sugar. That's wrong. Diet and exercise are the best way to decrease blood sugar. No, we only use insulin to treat gestational diabetes. Well, that's true. Well, for meds, okay, we we use diet and exercise and insulin. So B is sort of right, sort of not. It's not the best answer. We will try oral hypoglycemics if dietary modifications don't work. Wrong. Oral hypoglycemics cause birth defects. No, oral hypoglycemics can cause birth defects. There you go. That's the best answer. The reason B is not the best answer is because it says we only use insulin. We use diet and exercise and insulin to treat gestational diabetes. Okay, so D is the best answer because it gives her a clear response as to why we're not going to use oral hypoglycemics. For a woman diagnosed with gestational diabetes, which of the following best describes the recommended dietary modification? This is in the Blue Book, and I wanted to just make sure that you know this because this is a little bit different than the typical type 2 diabetic because we do calorie control with a typical type 2 diabetic, but mom here is pregnant, so we can't really do calorie control. We don't want her to cut calories in general. So what do we recommend? Increase in overall calories by increasing carbohydrates, fats, and protein. Increase in overall calories by increasing protein and fat. Increase in overall calories by increasing carbohydrates. Control calories to no more than 2,200 calories a day. D is out. We're not doing calorie control. And what we do is we don't want to increase carbohydrates. So we tell them to increase protein and fat in their diet rather than increasing carbohydrates. So it's not that they have to cut out carbohydrates, it's that they can continue to eat carbs, but you want it to be a little heavier on the proteins and the fats, preferably the proteins, probably more so than the fats. A pregnant woman has been diagnosed with gestational diabetes. Which of the following statements indicate that she understands the nurse's teaching? Understands the nurse's teaching. So we're looking for the true statement. I will expect to use the same amount of insulin every day throughout my pregnancy. That answer just doesn't make sense because that's not how we administer insulin in general. We administer insulin in general according to blood sugar. So it doesn't make sense that she would use the same amount of insulin throughout her pregnancy. Just my common sense radar is going off. I should expect to gain between 2 and 3 pounds every week during my third trimester. Y'all, normal weight gain during the second and third trimesters is 1 pound a week. Why would we want a diabetic woman to gain 2 to 3 times more than the normal? Obesity is a risk factor for this. We don't want them to gain 2 to 3 times more. We want them to gain the normal amount, which is 1 pound a week in the second and third trimester. So again, my common sense radar is blaring on B. If I don't go into labor on my own, I should expect to be induced between weeks 37 and 39. That makes sense to me. We don't want her to go to full 40 weeks because baby's already going to be big, which is going to be harder for her to deliver the baby. So unless we want to do a planned C-section, which we really don't want to have to do, there's no reason to do a C-section when baby is healthy. There's no reason to do a planned C-section. We can induce labor between 37 and 39 weeks. I understand I will need to be careful as I will be prone to low blood pressure due to my gestational diabetes. No, that's not true. They're going to be prone to hypertension. So we would want her to know that it's likely we're going to induce labor between 37 and 39 weeks. That's the true statement here. Okay, well, that didn't take too long to go through. I hope it was helpful. If you want to know more about diabetes in general, you can watch my other diabetes video. You would just Google diabetes clinic diabetes or Google it. I guess you can search it on YouTube. So bring that up, and I think that will be helpful to you. I hope you have a great rest of your week. Good luck on your standardized tests, your NCLEX. And for those of you who have passed and are still watching me, thank you so much. Congratulations. You're going to be great nurses. I know you will be. See you later.